Hello, everyone. Thank you so much for joining to talk about extreme heat. This is a recorded event, so I'm not sure when you're listening to it. Right now, where I am, it feels like about 102, so it's certainly a very relevant discussion. And hopefully you all will get something out of this. And heat stroke, heat attacks have been noted since the ancient times, and it's been noted to be a significant cause of morbidity and mortality. And I think collectively we tend to think of this as a problem of others, as a problem of other countries, other areas of the world, and we don't necessarily appreciate how close to home it is for us in the United States and specifically in New Jersey. We know, though, that over 80% or around 80% of the global population is experiencing about a month of extreme heat. Not just, a little bit above normal, but extreme levels of heat. And while we can't attribute any one heat wave to the effects of climate change and fossil fuel pollution, certainly in aggregate, that's what we're seeing. And I just took some snippets from the New York Times here. This was actually from about a month ago when I was first preparing this. So at the end of May, Miami had their hottest temperature on record. It was 112, which was 11 degrees above their prior peak. So when we talk about the Paris Agreement and being more than trying to keep below 1.5 degrees Celsius, we don't just have this 1.5 degrees evenly bumping everything up. You have these big excursions where it's like 10, 20 degrees hotter than a region ever had experienced before. It's deadly to plants and animals. And there's this really fascinating scientific study that was conducted, a heat wave scenario where they looked at 3 different cities. They looked at Detroit, Atlanta, and Phoenix. And they said, what would happen if there was a blackout across the city for 2 days with electricity gradually coming back on in the subsequent 3 days? What would happen in those cities? So in Phoenix, 800,000 people, or about half the population of Phoenix, would require emergency medical care, and about 13,000 people would die. In Atlanta, about 13,000 people would require ER visits. And in Detroit, because it's generally an older population and a poorer demographic, they would have about 220 or so deaths. And if you think in New Jersey, we're probably roughly a little bit more similar to Detroit than we are Atlanta or Phoenix. So certainly the effects of a blackout or even a brownout could have significant health consequences to the population. Now, when we're looking at how you calculate these mortality differences, we looked at observed versus expected. This is just how we calculate hospital metrics as well. So a few years ago in Europe, almost 62,000 people died from a heat wave then. Back in 2003, there was about 70,000 excess deaths. So this is already happening in northern latitudes in previously relatively protected environments where there's these huge impacts on human health and well-being, and certainly this is only going to increase in the subsequent years. So as I said, as we're experiencing more heat, it's not necessarily a uniform pattern. We see the whole bell curve move to the right. So that's why we have more extreme hot weather, but we can still have cold temperatures. You can still experience those, 20-degree days, but we're experiencing a lot more unseasonably warm weather. And there's not just a linear acceleration of problems with that increase. There's exponential changes. So as you go from 1.5 degrees to 2 degrees Celsius rise, you see essentially a decimation in things like the coral reef, which impacts human health. Aside from things like wanting to go snorkeling and scuba diving, it impacts fisheries. It impacts subsistence farming and also people who want to eat fish. Loss of plant species and insect species, again, greatly increased just with 0.5 degrees. So you see these climate tipping points that have direct impacts on how we live our lives. If you look through Washington Post and the New York Times, they actually have some really nice infographics. Um, this is, you can see from New York Times. I just took a screenshot a few days ago. You can see where the extreme heat is across the world. And if you're looking more locally here, you can see where we are in the Philadelphia, New York, New Jersey area. You can see that we're already in the dangerous zone right now of heat. And we almost take it for granted now. We're midway through July and we've experienced tons of these dangerously hot days. And in fact, New Jersey has increased our temperature more than any other a state in the continental US. And some of that is because we have so much impervious surfaces. About 17% of New Jersey is impervious surfaces. We're like a big parking lot. And so all of that amplifies the urban heat island effect. So New Jersey, and for a lot of other complicated climatologic reasons that I'm not sure I can fully explain, but certainly New Jersey is disproportionately impacted by extreme heat. And this is taken from the Department of Environmental Protection, but all of these impacts, things like rising temperatures, we also see related to that, hot air can hold more moisture. We see increased precipitation, sea level rise, ocean acidification, and we see changes in bird species and in our water becoming more salinated, having decimation of brackish marshes, things that protect us from flooding. All of that leads to direct health impacts. So we can see changes in water quality from things like salt incursions, salination, extreme weather. While we have increased precipitation, we also have more drought. And so we see both ends of the spectrum. And as that drought happens, when you concentrate water, you may have increased contaminants entering the water from that really increased precipitation, those big storms. But then when you have drought, you can also have concentration of all of those contaminants and things like PFAS and other things that we don't want to be drinking. And decreased air quality. So right now, when it feels like 100, 102 out, that high temperature has effects on ozone and on air quality, and so we see our air quality decreasing. And I'm not going to go through a big lecture on just how climate change happens, but just from a very rudimentary perspective, we have shortwave solar radiation coming in, and as we have more greenhouse gases like CO2, like methane, but also like the propellants in albuterol inhalers, also from desflurane, sevoflurane, isoflurane to a lesser extent, with our anesthetic gases. All of these gases trap the long wave radiation that's trying to get back out into the atmosphere, and hence the reason that we're in the shape we are. Now, a lot of the warming is actually going to the ocean. A large fraction of it. So we're actually not experiencing the brunt of it at this point. And an important concept, which I think we should all take note of, and our patients should take note of, is this that the heat index, and right now we're at about a 65% humidity, and so that really bumps, while it might be 94, 93 right now, it's going to feel like it's in the hundreds, and it pushes it into a much greater level of risk for our patients as the humidity increases, and we'll talk about why. So even though we get super concerned when we're above 100, 105, we also have to remember that temperatures above 80 can potentially affect human health, depending on the person, depending on the circumstances. If it's an outdoor worker and they have a comorbid cardiac condition, that person can be at greatly increased risk. So certainly there's temperatures above which anyone could experience heat-related illness. But as with everything, those who are going to be disproportionately harmed are those with disproportionate risks, like children, the elderly, those with comorbidities, those of lower socioeconomic status, certainly pregnant women. out of all of the weather-related fatalities, heat by and far causes much more deaths, and this is only anticipated to increase. Right now, annually, it causes about, I believe it was estimated to be about 350 in New Jersey. Heat-related death, it's expected to be up above 3,000 by the end of the century. Now, the way our bodies try to deal with heat-related disease is mainly through evaporation, but we also try to dissipate heat through conduction. You know, if you're sitting on an ice cube, or if you have a fan blowing on your face with convection. Radiation is where you have vasodilatation, and so you're trying to get rid of some of that core temperature elevation. Really, evaporation is how we primarily try to cool our bodies. And our bodies are much better at managing cold temperatures. When the temperature gets hot, our bodies were not really designed or not well designed to handle those extremes of heat. And so that's where we really end up coming into trouble. Now, there's many conditions that can result from heat-related illness, and I'll refer you to some excellent New England Journal articles that have come out, some review articles that have summarized heat-related illness and some of the comorbidities and mortality that can result from this. But heat rash, I'm sure many of us have seen. If anyone has children, you've seen things like this. Heat cramps is not necessarily purely a heat-related condition. It's where you have loss of electrolytes, and you can subsequently have some changes in muscle relaxation. Heat exhaustion is where you're starting to get into a much more dangerous end of the spectrum. We'll go into this in a little bit more detail. We also need to think about heat injury. And then we'll talk about heat stroke, which has been divided into exertional and classical heat stroke. Exertional being just what you think. It's the person who's delivering packages for Amazon and is out in the sun and lifting heavy things. Classic is that 78-year-old gentleman who's home alone, who's socially isolated, and both have high risks for mortality. This is not just regular hyperthermia or a fever. So giving things like Tylenol, salicylates are not going to help. But certainly all of the attendant complications that can happen with hyperthermia are going to happen with heat-related illness. So the increased basal metabolic rate, oxygen consumption. When you have heat exhaustion, your core temperature is not going to be above 104. When you have heat stroke, that's when you can't control your body temperature, and it's going to shoot above 104. Heat exhaustion, that's when you're feeling nauseous, you have a headache, you just don't feel so great. But then you can still exert behavioral changes and get in the shade or drink more. Heat injury is where you're actually having signs of progressive multi-system disorder, and you may have end organ damage as well, but you're not having central nervous system effects, which is a key distinguishing factor between heat injury and heat stroke. And again, with heat injury, your core temperature is going to be under 104 degrees. But you do have end organ injuries. So you might have a troponin leak, you might have some AKI. If you look at some of the CNS complications that happen, they can sometimes be very subtle. And especially if you have someone who is very old or very young, it can be hard to tell sometimes if there's irritability, if there's disorientation. I know we're adult medicine, but with teens actually have a very high rate of ER visits related to heat-related illness, and so it might be hard to tell emotional lability in a teenager. But certainly some of the end-stage complications are incredibly severe, and there's a very high mortality rate associated with heat stroke. And you can see that the pathophysiology associated with this. And there is a point after which you will not necessarily be able to remediate the CNS impacts. Heat syncope is another term. It's a little bit confusing because it is related to heat, but it's not a direct response from the heat. And you usually will see something like heat syncope after people are doing marathon training, or they're soccer players. They're engaged in a prolonged activity, prolonged exercise, and so they're maximally vasodilated, and their muscles are working. So their muscles are pushing back their blood supply to their heart. But when you suddenly stop that race, you're still maximally vasodilated, but your muscles are no longer pushing that blood back through your circulatory system. And so that's when exercise associated collapse or heat syncope can occur. And you still have to go through the regular differential because it's going to be a diagnosis of exclusion, obviously. Pathophysiology, you have to have an intact CNS and an intact cardiovascular system. It's going to be mediated through the anterior hypothalamus, through the preoptic nucleus, and as you have these impacts, you will become dehydrated. And there's an unfortunate spiral that happens because as you become more dehydrated and you lose body mass, your body is less able to cool itself, because if you think about it, you're becoming dehydrated. Your body can no longer shunt that blood to the periphery to cool down. You also have an increased metabolic rate, so you're putting even more stress on the brain as the temperature begins to rise. Now, I know this is a little bit complicated. We're going to we're going to go through this. We're going to parse through this. So behavioral thermoregulation is, I think, the easiest thing to consider. Getting a drink of cold water, getting yourself into a cooling center or an air-conditioned environment. Not everyone can do that. You know, if someone has limited mobility, if there are no cooling centers and they have no transportation, if they are afraid of crime and they don't have air conditioning and their windows are all closed up, their behavioral thermoregulation is not going to be equally available to everyone. Autonomic thermoregulation, we talked about sweating. So again, that's really a key ability for us to cool ourselves. We have to consider, though, as you become dehydrated, not only do you lose your ability to cool your body, your blood does become more viscous, which has been associated with increased thrombosis. And you can develop renal insufficiency. You can have electrolyte imbalances, particularly hyponatremia, but it can be hypernatremia. You can be having hypocalcemia, hypophosphatemia. You can have all different types of electrolyte abnormalities. With vasodilatation, so as you vasodilate, of course, you're going to be increasing your heart rate. So anyone who has attendant cardiovascular compromise, you can see how this would potentially worsen things like MIs, like arrhythmias. You are also going to be diverting that blood from other areas that need it. So not only from the kidneys and the brain, you're also diverting it from the gut. So you have decreased splanchnic flow because your body is going to preserve vasodilatation. It's going to try to cool itself no matter what other organs are being affected. And so as a result, people can have GI bleeding from this decrease in splanchnic flow. And you can actually see a scenario that mimics sepsis. Some of this is because of endotoxin directly leaking into the circulatory system, but also you'll have inflammatory mediators, heat shock proteins, cytokines being released. And so all of this perpetuates the organ dysfunction and the end organ damage that can potentially lead to death. So we talked about the increased consumption. Cytokine-mediated SIRS, heat shock proteins will sometimes necessitate people being started on antibiotics when they come into the hospital for a heat stroke. Gut ischemia, so you should always be looking for GI bleeds. Certain types of tissues, particularly hepatic, vascular, and neural tissues, are very sensitive. You'll almost always see a slight elevation in hepatic transaminases in someone who's coming in with a heat-related condition. And once you get above 100, about 108 degrees Fahrenheit, you'll actually have oxidative phosphorylation becoming uncoupled, and you'll have malfunction of many enzymes. So actually protein breakdown will happen as the temperature gets high enough. as people experience these kind of temperatures, like, you might be wondering if people are in Phoenix or they're in Florida, how do they become acclimated to this? So over a period of about 7 to 14 days, plasma volume will actually expand, and more of that will be fractionally shunted to the skin, more vasodilatation. You'll also sweat easier, so you'll have a lower threshold for sweating, and you'll have more sweat come out, and the sweat composition actually changes. So you'll have lower salt and lactate concentrations. And so all of this can be very adaptive, although of course there's limits. You can't acclimatize your way out of 110 degrees in Phoenix, but it certainly permits our bodies a little bit more resilience in this setting. Now, I'm not going to go over all of these, but just to say that every organ system can potentially be impacted by extreme heat. If we're thinking about those with asthma and COPD, you have an increased breathing rate, and so you can have complications from that. We already talked about the heart and kidneys and liver injury, and certainly CNS is very sensitive. We'll talk about some of the mental health impacts. I also want to highlight pregnancy, because this is a very, very vulnerable population. Pregnant women in particular are vulnerable. There's more body mass relative to the body surface area. So pregnant women are not able to dissipate the heat as much. The fetus also generates heat. And so not only is the woman at risk, but the baby's also at risk. So high temperatures, particularly with poor air quality, has been associated with stillbirths, with preterm labor, especially if you think about a woman getting dehydrated and being very hot, and birth defects, particularly congenital heart defects, cataracts, and neural tube defects. I won't go into all of this detail, but just to say that I would just like to refer you all to the New England Journal articles related to extreme heat. And if you're interested in looking at some of the additional studies that supports the multiple organ system impacts and health impacts, I would just direct you that way. We also need to think about things like heat burns. Asphalt can actually get up to 180 degrees. So in Phoenix, their burn unit has seen an explosion of burns just from an elderly person who falls and is on the ground for 5-10 minutes. It can even happen quicker than that. Someone who is unhoused, who is on the ground. It can be really serious third-degree burns. And inside cars, which is why vehicular hyperthermia is such a concern for pets and children. It can get really, really hot. It's certainly not your imagination when you open the car door and it just hits you. So in terms of epidemiology, again, with mortality, we usually refer to observed and expected. There are epidemiological ways of looking at this, and we're getting better and better at producing this type of research, and doing small area, individual level analyses that can then be extrapolated to larger areas. So in terms of ER visits, we even see above 82 degrees Fahrenheit, we see an increase in cumulative ER visits, particularly for mental and behavioral health, but for other conditions as well. And you can see some of the list here, not surprising, given the pathophysiology that we've discussed. And these don't necessarily happen on the first day of extreme heat. The real problem is when you have a couple days of heat, or when the temperatures are hot at night and the body can't cool down, because that's a huge stress response. If the body can't cool itself at least at nighttime, that stress is ongoing. So often 2 to 3 to 4 days after a major heat response, you'll see a spike in hospitalizations and ER visits. And again, that this has been shown for all-cause admissions, but for all the reasons that I had discussed previously when you look at a really high heat index. In this other study where they looked at several 22 million ER visits, there was about an 8% increase for visits to the hospital, and it was more pronounced in men and more in the Northeast. And the reason for the Northeast is because, again, we're not as acclimatized. So we have relatively cold winters, and then we go right into, 100-degree summers. So we see disproportionate impact. Now, who to admit this is not, this is, I think kind of common sense. So if they're still hypotensive or seizing, if they have kidney electrolyte abnormalities, if they have myalgias, because that can pose the potential for evolving rhabdomyolysis. They may have DIC or exertional hypoglycemia, certainly if there's GI bleeding. So you're going to work up these people, again, based on whatever they're presenting, but you want to have particular attention to things like looking for lactate elevation, for CK, for urine myoglobin. You want to be checking the calcium and checking EKGs. Potentially, you might want to do POCUS and get an assessment of the volume status. UDS, if you think it's appropriate. Certainly, there are illicit drugs as well as prescribed drugs that can have big impacts on our ability to thermoregulate. And because of the cardiovascular complications, chest X-ray, if you think pulmonary edema. If you really exhausted all of your thoughts about what could be going on with altered mental status, you could certainly consider a CT and LP, although it's not going to be the first thing that you'll do. Really cooling the person is the first thing you want to do. And then there are indirect effects. We alluded to the concentration of contaminants, PFAS, things like that, when you have drought. You'll also have a decrease in the food supply. When there's severe weather conditions, we're less able to grow crops. And in that bottom box, we had alluded to air quality. So air quality and heat, unfortunately, go hand in hand, because as there's more heat and sunlight, then volatile organic compounds, oxides of nitrogen will get converted into ozone. And ozone is really bad for us, really bad for breathing. It's bad for cognition, bad for our heart. Now, going back to that really bad heat wave in Europe where 62,000 people died, you can see this is the breakdown across all ages. And then you can see in the panel on the right, those people who are over 80 were disproportionately harmed. So, so many, many more deaths in an elderly population. And interestingly, in this study, we had talked about it in the US, it seemed like more men were harmed. In this study, it was actually more women that died. So I think the jury's still out. I mean, women do have proportionately more fat, and so that makes it harder to dissipate heat. Men may be in some cultures more out and exposed to the elements, so may put them at more risk. If you look within the US, the reason or more evidence, I should say, supporting that the Northeast being a vulnerable community, you can see this 4.39%. That is, so we have an increased relative mortality as the temperature starts to go up above the mean, about 4.4% compared to the South, where they're relatively used to the heat, and so they don't have that much of an impact. But we do not have the benefit of that acclimatization. And in this study, I know there's a lot of numbers here, but if you just look at the cardiovascular column, you can see there's a lot of negative numbers here. So there were actually fewer cardiovascular admissions, and that's because people with bad cardiovascular disease were dying before they made it to the hospital. They had sudden cardiovascular death in their home related to arrhythmias, related to myocardial infarctions before they made it into the hospital. Renal and respiratory conditions still increased, but so that's definitely something to consider. And if you talk to EMS colleagues, ER colleagues, they will talk about the same type of findings. Now, certainly the elderly are disproportionately harmed, and there's numerous reasons for this. I mean, first, thermoregulation deteriorates with aging, but then a lot of the medications that we're giving our patients impact risk perception and their ability to thermoregulate when it's really hot. They're also more at risk for isolation. If neighbors, family aren't checking on them, if they don't have access to air conditioning, then that's a big concern. These are just pictures from the Chicago heat wave in '95, which was infamous and is always referred to. But most of the individuals who died in Chicago were over 65. And again, we see a little bit of discrepancy in male versus female, but in the US, we saw more male, and a big risk factor living alone. Big risk factor if there's no air conditioning. So there's several factors that could potentially contribute. We talked about the BMI issues and the acclimatization issues, but alcohol, medications, being dehydrated before you even go into a heat situation, and prior heat stroke. If you're in the military and you have one episode of heat stroke, you're marked with the scarlet A. So people know that you're going to be more predisposed to have heat stroke again. So you may have to do a different type of work. So going to the medications, we have to think about the medications not only having physiologic impacts, but also the medications can be altered by heat. So, and if you think of all the mail order medications that might be sitting out in the sun for 5 hours before they get picked up, albuterol canisters actually explode above 120 degrees, and people might keep them in their car and not think about it. The medication, if it doesn't explode, the medication just won't be released as effectively. Things like Synthroid, things like EpiPens all get inactivated by the heat, and certainly insulin. And then we have all the medications that we need to consider that have impact. So for all of our cardiovascular patients, if we have them on beta blockers, that's going to impact their ability to augment their heart rate. If they're on diuretics, they're going to be getting volume depleted before they even go into a heat situation. People who are on stimulants for ADHD are going to be less able to regulate their heat and have higher baseline temperatures. Antipsychotics are the worst. They impact, they have all kinds of physiologic impacts. And certainly anything with anticholinergic effects are going to potentially impact the ability to thermoregulate. Alcohol is another concern. Even caffeine, because caffeine can lead you to be more dehydrated. Certainly things like cocaine and ecstasy. Again, the psychotropics are really bad, but almost you really have to take a fine-tooth comb to a medication list and see what is not going to be impactful in heat, and counsel your patient. We don't necessarily want them stopping all of their medications, but maybe they need to be checking their weights more frequently. They might need to decrease that furosemide dose. It's just kind of looking at everything with a fresh set of eyes to make sure that we're not harming our patients as we're trying to treat them. One kind of interesting thing to mention too, and that this is not a medication, but people down energy drinks and all kind of stuff, in the hopes of rehydrating when it's hot. And for people who are drinking any kind of sugary beverage while they're hot, that can actually worsen CKD, and specifically CKDU, or Mesoamerican nephropathy. And it's in part because of the fructokinase mediated glucose cycle, but also vasopressin and aldose reductase. So one easy thing that we can tell our patients is don't be drinking any sugary beverages when it's hot. Just rehydrate with water. If if you're rehydrating with Gatorade, make sure that it does not have sugar added to it. So high risk populations. And these are a lot of the people that we're seeing. It's people with mobility, cognitive challenges, a lot of people in urban areas, certainly outdoor workers. But there's this balance of susceptibility, which are all the internal factors, like, if it's a man or a woman, the extremes of age, the coexisting conditions they have, and then external vulnerability factors. So, do they not have access to air conditioning? Do they have low health literacy? Are they from a marginalized social group? So these are just some other examples of people that we should potentially be concerned about. Even sports enthusiasts, sometimes they can overdo it and not necessarily be thinking about the risks to themselves. Laborers, and interestingly, with people who work outdoors, even when heat-related illness does not go up, there will be a ton of accidents that go up. So falls from ladders, hitting with hammers and, fractures and things like that. So a lot of ostensibly unrelated accidents will spike as you have unseasonably warm weather. And certainly those who are unhoused, we get worried about. Now, schizophrenics, as I had alluded to, antipsychotics cause a lot of problems, but our schizophrenic populations are noted to be 200 times more likely to die in a heat wave. So if we had to target one population, our patients with schizophrenia are really, really at risk. And this is for behavioral reasons, but also because of the effects of the medication. If we think about other vulnerable populations, we often don't necessarily think about the prison system, but incarcerated individuals are very vulnerable, often are taking psychiatric medicines and hypertensives. They have underlying risks. And many of these places may not have air conditioning, particularly as you can see that this list, most of them are in the South. But certainly this is a health issue and a human rights issue as well. I'm sure many of you have heard of the concept of urban heat islands. And as I had alluded to, all of New Jersey is kind of an urban heat island. But there's a big difference when you're in the middle of a city with no trees versus when you go out to the suburbs, sometimes just a distance of a mile can have big impacts. Now, this is all based on the practice of redlining, which started in the 1920s with the Homeowners Loan Corporation. They went through and they literally lined out different areas of the neighborhood, and those areas that were desirable were generally affluent. You can see in the green, and the less desirable or the declining areas were in the yellow and the red. And as you can imagine, those literally redlined communities were more Black and brown, more immigrant populations, and that redlining had long-term impacts on the community. So those redlined areas had less tree cover. You can see very clearly, the areas that were green have tons of green there, tons of trees. Redlined areas don't. They also have more paved surfaces, those impervious surfaces. And as a result, they have higher summer temperatures. Again, not surprising. You take away all the trees, temperatures are going to go up. Now, local to us for Philadelphia is about 7 down, and then New York towards the bottom. For Philadelphia, there's about a 10-degree difference between the most desirable and the least desirable areas to live. And there's another big spread in the New York area as well. So these have real health impacts. In Philadelphia, there was a study that actually showed that in different areas, there was a 31-degree temperature difference on hot days, just looking at areas that had and did not have vegetation. So you can imagine the health impacts from that. And this is just from New York City. You can see the areas with vegetation, the nice green lush areas, where Central Park is, and then you can see the differences in the temperature, much cooler wherever there's a lot of vegetation. So mental health issues, Shakespeare noted this. So it's not only an issue for things like anxiety, depression, but even for cognition. So for students, higher temperatures have a big impact on their educational achievement. And as you can imagine, again, Black and brown communities are again disproportionately impacted. So if you think of the different ways that social determinants of health can impact, you can see that not having an air conditioner can potentially impact school learning, such that every 1 degree Fahrenheit decrease the amount of learning by about 1% in that population. And then mental health impacts. So we see an increase in death from psychosis, substance abuse. There's more suicides. There's a significant increase in interpersonal violence, domestic abuse, homicides, and a lot more things like anxiety, depression. There's been modeling to even look at how climate change will impact crime. And so you can see that most of this is going to be related to heat. You can see that this modeling and how we're expecting to see change by the end of the century. Just going to skip through some of this. For Mesoamerican nephropathy, we already kind of alluded to it, but it was first identified in El Salvador in sugarcane workers because they're exposed to very high temperatures. They're out in the field all day, going further and further from their truck without hydration, often without urinating until the end of the day. And all of these young male workers were showing signs of renal insufficiency. It's now been shown to be in several areas besides just Mesoamerica and in El Salvador. But there are areas in Nicaragua, for example, where up to 41% of the young men between 25 and 40, I believe it was, had significant kidney disease. So it has real health impacts. Again, this is taken from the New England Journal. A lot of these impacts are because of increased core temperatures, because of rhabdo, because of crystalluria. A lot of times these workers would report peeing out sand at the end of the day, and when they looked, it was actually urate crystals that were found in their urine. It's been found now really all over. So there's an Udinam nephropathy. It's been found in Sri Lanka. So in terms of treatment, time is really of the essence because we have a small window to address these people. So you want to cool people as quickly as possible and then hospitalize and evaluate for late complications. So if people are at endurance events, that there's often planning out there, that they have tents, they have cooling devices, they can even measure serum sodium, whereas EMS cannot. You want to try to do rapid cooling. You want to get them as cool as they can in the field or during transport. But again, ideally, you want to do cold water immersion. So sometimes mobile units will have body bags and they'll fill with ice and directly immerse people. If you don't have that, you can do wet towel circulation, especially on the axilla, the neck, the groin. If you have to, just dousing people with cold water. You can apply ice packs if people are intubated. If they're not intubated, it's not going to be so well tolerated. People don't like to have ice packs on their neck. There was interestingly a small randomized controlled trial where with athletes, they put cold compresses on the cheeks, palms, and soles, and that was actually very effective. It was more effective than traditional cooling. And you could even, there was a case of intranasal cooling in an 80-year-old that was successful. So you want to get the temperature down to about 101 or 102 and get that person into the ER. There's actually little evidence to support things like chilled IV fluids, lavage, cooling blankets. It's not to say don't do it. It's just to say that we don't necessarily have the best evidence to support it. You definitely want to avoid an alcohol sponge bath because that can get absorbed through dilated vessels. So you don't want that. So that's what an ice bath looks like. It doesn't look like so much fun, but it can be life-saving. As you're monitoring their temperature, it really has to be rectal because if you have, as you can imagine, all of this vasodilatation, you can't really trust a cutaneous temperature. You need to have a core temperature. If you can't get it, you want to cool them for about 15 to 20 minutes, assuming that their temperature would probably drop about 3 to 4 degrees, or wait until they shiver and then change method of cooling after that. So you want to do all of your regular ABCs. Again, we talked about the goal temperature. You really want to be attentive to the mental status because it can fluctuate quickly and it can also be very subtle. You want to be looking at the muscle compartment. So people can develop rhabdo, they can have compartment syndrome. It also helps to differentiate from other conditions because if there's rigidity, you shouldn't have that with heat stroke. If it is rigid, then you might want to think about medication complications like malignant hyperthermia or neuroleptic malignant syndrome. And again, as we talked about, GI bleeding can happen. So make sure that you're looking at all the orifices for possible bleeding. SIRS protocols can be implemented every hospital has a SIRS protocol, so that can be put into place. Aggressive fluid resuscitation up front, and just like with sepsis, we don't have the best guidance for how long to continue fluid resuscitation, but you don't want to necessarily keep them with backs wide open for days because they'll start to third space. You want to be correcting electrolytes, and certainly if you think that the hyponatremia happens suddenly, you can consider hypertonic saline if you think it's appropriate. And complications, particularly those cardiovascular complications, those are going to be very significant. And as I mentioned, heat stroke is a different pathophysiology than fever, so you don't want to do things like aspirin or Tylenol. And in fact, that can actually exacerbate complications like AKI, like liver problems, and salicylates can contribute to hyperthermia because it will actually uncouple that oxidative phosphorylation. So you can make things worse by giving them salicylates. If people are seizing, you can give them benzodiazepines. The benzos have the benefit of maybe resulting in a little bit of cooling in and of themselves. Same thing, you can do some midazolam for agitated delirium if that happens. You're going to be intubating if there's ARDS, managing rhabdo with fluids, AKI, and hepatic injury. And if there's GI bleeding, again, you might need to involve your GI colleagues. MIs, if the person has made it to the hospital, they'll generally resolve with rapid cooling. Cardioversion and antiarrhythmics usually are not effective unless the patient is cooled. So not to say it shouldn't be tried, but it's less likely to be effective. You could consider norepi if the person remains hypotensive after adequate IV fluid resuscitation, but you certainly want to avoid alpha-adrenergic agents because you don't want to be peripherally vasoconstricting when you're trying to dissipate heat. If people are agitated and shivering, benzos can also help. And if it's really severe and you can't get the temperature down, there have been reports of doing paralytics. And there's some interesting literature out there about having a period of hypothermia, just like we do with ROSC in the hospital setting. Having a periodic hypothermia may actually preserve some of those neurons and minimize the heat-related inflammatory response. With athletes, we really have to counsel them in the preseason because the worst problems are usually in the beginning of the season. For football players, it's happening at the end of summer when they're putting on all of this heavy equipment and they might be not in the best shape. And usually these athletes are particularly big, and so they don't have as much skin surface to dissipate the heat. We should be hydrating before they go out, usually telling them to drink enough so that you urinate before you go out, because at least you're hydrated at that point. Don't increase salt intake. And you could potentially recommend doing things like pre-cooling, drinking an ice slurry or a cooling vest, things like that before they begin their exercise. Now, there's some misconceptions out there. So one of the big ones is that people will stop sweating once heat stroke sets in. That's usually not the case, and it can also delay diagnosis. People will almost always be profusely sweating at some point. People can be hydrated and still develop heat stroke, and heat stroke can actually develop within 15-20 minutes, regardless of hydration status. As we said, you need to have a rectal temperature. A lucid period does not mean that the individual is okay. It can be really subtle and hard to detect. There's concerns about shivering, delaying the cooling. The cooling should still be continued even if the individual potentially is shivering, but hasn't hit that 15-20 minutes of being in the ice bath, and it will still work. Heat stroke is unpredictable, so there's a lot of risk factors that we know. Aside from acclimatization, things like sleep deprivation. If you already have an infection, that's also not a good place to start. If people are obese, if it's a high intensity type of exercise, these are all going to be known risk factors. But the condition doesn't have to occur on a continuum. You can go from fine to heat stroke. You don't have to go through heat exhaustion, heat injury in order to get to heat stroke. Cold water immersion increases drowning risk. People just have to be supervised. It's a life-saving intervention, so it should certainly be considered whenever possible. People may have bleeding or vomiting, but again, you're balancing that against organ system damage and death. You always want to use a rectal thermometer. Certainly, people can have a period of hypothermia, and you may just want to monitor that. Peripheral vasoconstriction delays cooling. And this is again, like, if you're in like a cooling bath or something like that, it really has little impact. If you're immersed in an ice water bath, you're going to cool your body temperature down, so it should still be continued. And yeah, it might be uncomfortable, but it doesn't cause significant harm. So in terms of thinking about what else we can do, we really need to communicate with our patients. We need to communicate with caregivers across health systems and really across government. So we'll talk about some of the tools that are just now being developed to address this. But we also need to think about resiliency planning. Are there cooling centers? Are there ways to get to cooling centers? Transportation? Are there backups if there's a blackout or a brownout for particularly vulnerable individuals? And if you look at the mortality, the classic heat stroke has up to a 65% mortality rate. So really, really sizable. Even among athletes, exertional heat stroke can have about a 5%. So very, very significant. Right now, there's discussions in OSHA. 30 individuals are deciding on standards that could potentially impact 50 million outdoor and vulnerable workers. These are people who might be cleaning airplane cabins or working in hot kitchens or sorting packages in that Amazon warehouse. So that is still up in the air, still being decided, but it's important that we as physicians see these type of actions as being public health initiatives. And just to refer again to some of those New England Journal articles, there are steps that we can take both at a policy level and at an individual level. Things like health checks, getting people to cooling centers, having a heat action plan. All of those are things that you can do at the individual level. But then more globally, we can be educating our populace, creating more green infrastructure and more reflective surfaces or albedo surfaces. For people who have heat cramps, again, a less serious condition, but stretching, sodium replacement with sports drinks, things like that can certainly help. Heat syncope, supine with raised heads in a cool area. Again, you still have to go through your regular differential. And heat exhaustion, you're going to be cooling just as you would for other heat-related illnesses. Sorry. Fans. So there's been this whole flurry of studies about fans. And it seems like once the temperature is above about 95 degrees Fahrenheit, fans are not effective because you're essentially just turning it into a convective oven. You're blowing hot air. We usually with cooling, we'll have a little tiny bit of cool air above our body. And so when you blow hot air, you're just blowing that vasodilatory cooling away. So we really need to be thinking about the fan recommendations. And for other recommendations, I usually tell patients to download the OSHA NIOSH app because it's very easy to use. It's color coded, and just telling people to look at it on a regular basis, making sure that people are staying hydrated, you wearing lighter clothes, wetting down clothes, avoiding sugary and alcoholic drinks, and also heavy hot meals, because all that blood is going to be shunted to the gut. And so we want it, if people are hot, to be shunted to the periphery. So lighter meals, and definitely reviewing all of your medications. Let's skip through this. There's also infographics you can post in offices, in public spaces. This one is from the CDC. I really like this one from Lancet. So this is something that can be printed and posted in public areas. This is a new tool. So heat risk has been recently developed by the CDC. And so if you go on their heat and health index, they code areas based on zip code tabulation areas. And you can directly see heat and health outcomes for your particular community. This is just a snapshot from for Newark. So you can see that 94% of areas in the country are less vulnerable than this area of Newark. And you can do a deep dive into this. And again, this is going to CDC Heat and Health Index. You can do a deep dive, and then you can see where is the burden coming from. So in this case, it's coming from sociodemographics and the natural and built environment. If you wanted to download the data, if you have a hospital database, if you have other databases that you would like to sync up, you can actually download the data from the CDC. And then they also have a heat risk dashboard. So this gives a 7-day outlook. Again, it's color coded. They also pair it with airnow.gov air quality levels, and they give direct heat recommendations, heat and health recommendations, which is really helpful. So you can go to the physician or health provider part of this, and you can download direct guidance that you can share with your patients. They have this mnemonic that we should be remembering when we're interviewing our patients called chilled out. And it's just things like, do they have housing? Do they have electricity and refrigerated meds? And are they able to look at an app for this information? So it helps to remind us of some of the social determinant of health impacts. You can download all of these toolkits, and you can also download action plans. Just like there are asthma action plans, you can download from CDC heat action plans, which are really, really helpful. And this is the updated CDC graphic on extreme heat and heat-related illness. OSHA also has resources on how to help support our patients, like with LIHEAP, to try to keep their energy bills covered. And there's a heat and hub that's a collaboration between the Department of Health and the Department of Environmental Protection in New Jersey. And this can help to link people with cooling centers with additional information. So just some links to some of these. I know that there's a lot of resources out there. It helps to have more information than less so, and certainly we want to share this with our colleagues and with our patients. And if people are interested in being involved in advocacy or health policy, please feel free to email me directly. I'm happy to get you involved with our ACP Health and Public Policy group. Thank you so much, and thank you for spending time with me today.